My name is Isabella Ginta, and for my fourth sports medicine project, I did rehab for an autograft of the ACL. What is an autograft? An autograft refers to a surgical procedure where the tissue is taken from one part of a patient's body and transplanted to another part. For example, in an ACL reconstruction surgery, a surgeon might use a piece of a patient's own tendon, like their hamstring or patellar tendon, to replace their damaged ACL. What is rehab? Rehab is short for rehabilitation. It is a process of treatment and training aimed at helping someone recover from an illness, injury, or surgery. It focuses on restoring function, improving mobility, and helping the person regain their independence. Goals for my rehab program: reduce pain, improve strength and flexibility, restore movement and coordination, prevent further injury, improve overall physical and mental well being. My plan will consist of 6 phases: immediate post op, which is 0 to 2 weeks, early rehabilitation, 2 to 6 weeks, strengthening and progression, 6 to 12 weeks, return to function, 3 to 6 months, return to sport, 6 to 12 months, maintenance and long term care, 12 months and beyond. Phase 1: the graft site must be kept stable, allowing the site to begin healing. Wearing a brace or an immobilizer will help with that to stabilize the knee in the early stages. By using Price, it will help to reduce pain and swelling. A few days after surgery, you want to start working on gentle range of motion. Goal for this would be achieving near full knee extension and regaining some flexion. At least 90 degrees is the aim for the end of the 2-week period. Some exercises that will help: isometric quadricep contractions to activate the quads and begin preventing muscle atrophy. Heel slides to gently improve knee flexion and restore mobility. Straight leg raises to strengthen the quads and hip flexors while avoiding knee movement. Calf pumps to promote circulation and prevent blood clots. Phase 2: continue improving knee motion with particular emphasis on achieving full extension and restoring functional flexion. Proprioception and balance training are introduced gradually during these phases to improve knee stability and prevent future injury. Begin more non-weight bearing and introduce balance and proprioceptive exercises. Goal for this would be flexion should ideally be 90 degrees by the 2 to 4 week mark, and ideally progressing towards 120 degrees to 130 degrees by the 6-week mark. Exercises that will help: cycling with a stationary bike or with minimal resistance. It is encouraged as it's low impact exercise to help with range of motion and strengthening. Standing on one leg, use support for safety if necessary. In these few weeks, you're not very stable and you're working towards that. Balance board or Bocce ball, start with minimal movement and progress to dynamic balance exercises as strength and stability improve. Phase 3 focuses on building the strength in the quadriceps, hamstrings, and hip muscles and calf muscles to support the knee joint. Proprioception and balance exercises become more dynamic. Full weight bearing walking by the end of this phase. Most people are able to walk without crutches and without knee brace, though you still may need a brace during higher impact activities. Ensure full knee extension and continue to improve flexion, bending towards 130 degrees to 140 degrees. Some exercises that will help are hamstring curls, machine or resistance band. Start with light resistance, increasing the load gradually as strength improves. Step ups, step onto the platform using the injured leg, then step down. Start jogging on a treadmill at the end of the 12-week phase. You may start light jogging on a treadmill. Focus on short intervals of jogging and walking in between, gradually increasing the time spent jogging. Phases 5 and 4. This is 6 to 12 months. Continue strengthening and work on dynamic stability. Begin light running and cutting drills. Some of these might consist of squats, lunges, single leg exercises, and plyometric drills. Begin sport-specific drills and more complex movements, plyometric drills, sport-specific training like dribbling or shooting, full return to sport preparation, high intensity sport specific drills, full intensity agility drills, strength testing, and final readiness evaluation. Tests to help you return to play. A detailed return to play protocol is followed by like whether your knee can handle the demands of activity without risk of re-injury. Common tests include hop testing. This tests the strength and balance of the function of the injured leg compared to the non-injured leg. Strength training. This tests the strength of both the quadriceps and hamstrings of the injured leg. Vertical jump test. A vertical jump test can help assess power and strength as you approach functional activity. Specific simulation. Simulation game like conditions to assess the knee's ability to perform at high stress situations. Phase 6, sustain strength and conditioning, prevent re-injuring, ongoing proprioception and agility training, gradual return to high impact and complex activities, long-term monitoring and rehabilitation. Autograft versus allograft. An allograft involves using tissue from a deceased donor, which is typically called a cadaver. The most common source of the tendon tissue from the patellar tendon or the Achilles tendon or the hamstring tendon. An autograft uses tissue from the patient's own body, most commonly from the hamstring tendons or patellar tendon or quadricep tendon. Your body can reject an allograft due to it not coming from your own body and coming from a cadaver's body. Conclusion. While ACL reconstruction can restore knee stability, the risk of re-injuring remains higher in the few years after surgery, particularly if you want to return to sports too, quickly or without proper protocols. The physical aspect of the recovery shouldn't be overlooked, especially after returning to sports. Some athletes experience knee-related anxiety or fear or re-injury. This can affect performance and willingness to engage in high-intensity activity. Ultimately, the decision between an autograft and an allograft should be made in a consultation with your surgeon, taking into account your activity level, age, and specific of your injury. However, if you want to best chance for a smooth recovery and stable knee, choosing an autograft is the choice that will serve you well in the long run. Thank you.